You encounter an allergen, your immune system releases histamine, and these familiar raised red welts appear on the skin. Medically known as urticaria, a true hive follows 3 strict clinical rules. It itches immensely, it blanches white when you apply pressure, and it vanishes in under 24 hours without leaving a trace. But occasionally, a patient presents with a rash that perfectly mimics the appearance of hives, while ignoring every one of those fundamental rules. This clinical refusal to follow the standard patterns of allergy suggests a pathology located much deeper in the tissue, requiring us to look past the surface of the epidermis. This timeline contrasts a typical allergic reaction with our clinical imposter. First, these lesions persist well beyond 24 hours. Second, the itch is replaced by distinct pain and burning. Finally, instead of clearing completely, they leave dark, bruised patches of residual purpura. The presence of bruising and burning signals a transition from simple surface sensitivity to a process involving the underlying architecture of the skin. This pathology is anchored in the deeper microvasculature, specifically within the post-capillary venules. In a type 3 hypersensitivity reaction, circulating antibodies lock onto target antigens in the blood, linking together to form dense molecular structures called immune complexes. Because of their size, these immune complexes drop from the blood and embed into the endothelial lining. Once lodged, they trip a biological alarm, releasing C3a and C5a anaphylactocins. These act as a chemoattractant, pulling circulating neutrophils out of the bloodstream toward the embedded complexes. Through this targeted chemical signaling, a structural blood vessel is transformed into an active biological battleground. The arriving neutrophils operate with an aggressive directive to phagocytize and digest those embedded immune complexes. Because the complexes are entrenched in the vessel lining, the neutrophils unleash their internal payload of degradative lysosomal enzymes and reactive oxygen species, catching the surrounding vessel tissue in the crossfire. The intensity of this local inflammation is fatal to the neutrophils themselves. They rapidly degrade and violently burst in a process known as leukocytoclasis. This cellular death leaves a distinct histological fingerprint, scattered cellular debris called nuclear dust. Under this enzymatic assault, the vessel wall undergoes fibrinoid necrosis, destroying its structural integrity. With the barrier dissolved, red blood cells leak through necrotic gaps and spill into surrounding tissue. These leaked red blood cells trapped beneath the epidermis are the reason this condition presents as dark, painful purpura rather than a rapidly fading allergic redness. Confirming this microscopic destruction in a living patient requires a physical tissue sample. The gold standard is a punch biopsy taken from the non-ulcerated edge of an active lesion, ideally within 24 to 48 hours of its appearance. Pathologists examine this specific core of tissue under a microscope, hunting for that signature nuclear dust to officially confirm a diagnosis of leukocytoclastic vasculitis. Identifying these damaged vessels under the microscope provides a definitive localized diagnosis, which then necessitates a search for similar damage elsewhere in the body. Clinicians must now determine if the patient has a self-limited skin condition or a systemic disease known as hypocomplementemic urticarial vasculitis syndrome, or HUVS. The markers for HUVS include anti-C1q antibodies, which drive a severe, measurable drop in C1q, C3, and C4 complement levels. This measurable drop reflects a systemic depletion of proteins as immune complexes target the internal architecture of the lungs, kidneys, and eyes. This comparative table summarizes the divide between simple urticaria and a destructive systemic vasculitis. When hives burn, bruise, and refuse to leave, the standard rules of allergy have been broken. Clinical success depends on looking past the skin and investigating the entire systemic network.